Now I'm going to talk about the vascular supply to the brain. I divided talking first about the arteries, and then later about the veins. So I'm going to start very briefly talking that the brain has two systems of arteries. It has one anterior system called the internal carotid system that will branch into these two major arteries, the anterior cerebral artery and the medial cerebral artery. It also has a posterior system, also called the vertebral basilar system, that will branch into these main cerebral artery. That's the posterior cerebral artery. The internal cerebral artery, the internal carotid artery. The internal carotid artery, authors have described several ways to subdivide these into segments. I personally like these divisions, but in the literature there are always other ways to subdivide the internal carotid. So here there is C1, that is the cervical segment of the internal carotid. It's located inside the neck, is the cervical segment. Then we have a petrous segment inside petrous bone. It's actually the petrous portion of the temporal bone, okay? Petrous segment. Then we have the intracavernous carotid, that's the cavernous segment of the internal carotid artery. And then we have the supraclinoidal artery. The first one, the cervical artery, is located inside the neck. It will get to the carotid canal here. And the carotid canal, it will get inside the petrous bone. This is this bone here, the petrous part of the temporal bone, petrous bone. Here there is a channel here, a canal that comes from this opening here to the foramen lacerum. So it has this anterior and medial trajectory, okay? At the foramen lacerum, it will bend superiorly and get inside the cavernous sinus. So if we see the skull base from superiorly, we cannot see this channel here because it's inside the petrous bone. But in most of people, some part of this channel will be already opened, a little bit exposed at the middle fossa surface, okay? So here we can see at the center, the sella turcica, and lateral to the sella turcica, on each side, we have the paracellular space that we will find the cavernous sinus. Here we have the foramen lacerum. Here is where the petrous carotid will bend itself to turn into the cavernous carotid, here located one on each side of the sella turcica. At the center here, we can see the pituitary gland with the pituitary stalk over it. Posterior, we see the dorsum sella, and the pituitary gland is inside the pituitary fossa, the sella turcica. The cavernous sinus, one on each side, cavernous sinuses, will have neurovascular structures. We're not gonna talk about this, but it has several nerves inside it. But here we are talking about the artery that is inside, is the cavernous segment of the internal carotid artery. So let's see the cavernous sinus from laterally. We already removed some of the lateral wall of the cavernous sinus, and now we removed all its lateral wall to show what nerves will make the lateral wall of the cavernous sinus. So coming from superiorly to inferiorly, we'll have first the oculomotor nerve, then the trochlear nerve, then the ophthalmic nerve, the V1, coming from the fifth nerve here, the trigeminal nerve. All these three will make the lateral wall of the cavernous sinus. V2 and V3, they are already inferior to the cavernous sinus. Some people will say they are not part of the cavernous sinus, so the cavernous sinus will finish medial and superior to the foramen rotundum here, okay? And V1, trochlear and oculomotor, they will exit the cavernous sinus through the superior orbital fissure here. Okay. If we open the cavernous sinus, we'll see the sixth nerve first, and then medial to the sixth nerve, we'll see the cavernous carotid. The cavernous carotid has a sinus trajectory here. So it first has a vertical segment, then a posterior band, horizontal segment, anterior band, and anterior vertical segment. It's all inside the cavernous sinus. At this trajectory, its main branch will be the meningoepiphyseal trunk. The meningoepiphyseal trunk will be actually the origin of three arteries. There is the tentorial artery called the Benarconi-Casinari artery that will supply the tentorium. There is the dorsomeningeal artery, and there will supply the meninge, the dura mater of the dorsum sella, and it has the inferior epiphyseal artery that will supply the pituitary. Later on, I don't see in this specimen, but usually at the horizontal segment, we'll have the inferior artery of the cavernous sinus that will go laterally and supply these foramens here and the lateral wall of the cavernous sinus. Now we are gonna remove all these structures and drill a little bit of the floor of middle fossa, and also we are gonna do the anterior clinoidectomy. This is remove the anterior clinoid. At this stage here, we can see that by removing the anterior clinoid, we can see that the layer of dura mater that was covering the anterior clinoid continue medially and will wrap around the carotid, making a ring. This is the upper ring. And the dura that covers the inferior aspect of the anterior clinoid will also continue medially and embrace and wrap around the carotid, making also a ring, but this is the lower ring. And between both rings, we'll have a collar that embraces, just like a necklace. It will embrace ICA here, the carotid here. It's called the carotid collar. Okay, so here's all intercavernous carotid here, and here is the petrous carotid. Here's the petrous segment of ICA here. Okay, already inside middle fossa, inside the cavernous the carotid canal. Now let's talk about the supraclinoidal segment. The supraclinoidal segment is already intradural. It's already after the upper ring. It has three main branches. The first main branch is the ophthalmic artery. The second one is the posterior communicating artery, and then the anterior choroidal artery. And then it will bifurcate into ACA and MCA. Let's see these main branches here. To see the ophthalmic artery, it will originate most of times, more than 90% of times, from the supraclinoidal ICA already. And it will be inferior to the second nerve, and will go also through the ophthalmic foramen to the optic foramen to inside the orbit. So it's very narrow here, and in order to see this artery, we'll have to do the anterior clinoidectomy also. Of course, I cannot displace the second nerve like this. I'm just doing this to show how the origin of the ophthalmic artery is very proximal to the upper ring. Sometimes it will originate, the ophthalmic artery will originate itself from the cavernous carotid. The other branches, we can see just like a surgery. So we made the skin flap, we elevated the skin flap, we elevated the temporal muscle, we did a craniotomy, pterygoid craniotomy. Here we located the Sylvian fissure, and now we split the Sylvian fissure. If we split the Sylvian fissure, we'll get in contact with MCA branches, and if we follow MCA branches, we'll get to M1 and later to the ICA bifurcation. And at this point, proximal to ICA bifurcation, we have the supraclinoidal carotid, this segment here. Ophthalmic branch, we cannot see this picture here because it's a very proximal origin, and it's already inferior to this nerve here. This is the optic nerve. connecting with the, on the other side with the optic chiasm, through the optic chiasm. Here we see the posterior communicating artery next to the oculomotor nerve. This is why aneurysms from this artery here can harm the oculomotor nerve. They are very close together. And the communicating artery, the posterior communicating artery, will come from ICA towards PCA, towards posterior cerebral artery. We're going to talk about this later. Then we have the anterior choroidal artery, and then ICA bifurcation into ACA and MCA. There is also a circle of Willis, the polygon of Willis. The polygon of Willis is very interesting because it describes three communicating arteries. They are really communicating the anterior system to the posterior system, the left vessels with the right vessels. So the anterior communicating artery is a single one, and it will connect both ACAs, both anterior cerebral arteries. It's a single one, anterior communicating artery. Then we'll have two posterior communicating arteries. The posterior communicating arteries will connect ICA with posterior cerebral artery here. Let's see how the polygon of Willis look on reality. Is a little bit more complicated and has a lot of information at this image here. So at my mouse here, you can see ICA. If we follow ICA, here's ICA bifurcation. So laterally, we'll have MCA, middle cerebral artery. Medial, we have ACA, anterior cerebral artery. If we follow anterior cerebral artery, you can see here, anterior communicating artery communicating with the other side, with the right side ACA. So left and right ACAs are connected together through the anterior communicating arteries. At this point here, we can see that we already mentioned all these perforating arteries that are arising from the proximal segments of M1, A1, and ICA bifurcation. These are the lenticular right arteries. They're perforated in the anterior substance and supplying the anterior part of the central core. Now let's go posteriorly here. We can see the basilar artery here. The basilar artery at its top, it opens into two PCAs, one for each side. It has the lateral, the left and the right PCA, posterior cerebral artery. If you follow the posterior cerebral artery, you can see it here, the posterior communicating artery. The posterior communicating artery is really communicating the ICA with the PCA. And it's the point where we can subdivide the PCA into P1, which is proximal, and P2, which is distal to this connection with the anterior communicating artery. Inferior to PCA, we have the oculomotor nerve, and inferior to the oculomotor nerve, we have the SCA, superior cerebellar artery. It's always this anatomical relation here. So PCA superiorly, oculomotor nerve, and then SCA. Middle cerebral artery, to understand this trajectory, we need to understand the Sylvian fissure. The Sylvian fissure, this is the lateral extension of the Sylvian fissure. With the Sylvian fissure, we will also have a stem or a sphenoidal compartment of the Sylvian fissure. This is where M1 is located, okay? So ICA will be at that point here. ICA will bifurcate. ACA will be on top of the chiasm, and MCA will have this trajectory here, okay? But from the bifurcation to the limen insula, that's this point here, we'll have M1, and then M2 over the insular surface, M3 over the operculum, and M4 over the lateral surface of the brain. It's a more enlarged view, just to see how this anatomy is beautiful. ICA will be at that point here, ACA will go here, MCA will go here. So M1 to the limen insula, M2 at the insular surface, M3 at the operculum, and M4 at the lateral aspect of the brain. Let's see here, the surgical point of view, ICA bifurcation, ACA on top of the chiasm medially, MCA laterally, M1 from bifurcation to limen insula, M2 further on. We already showed these pictures just to show that from M1, lenticular striate arteries will arise and supply the anterior part of the central core. So here it's perforated, anterior perforated substance and supplying the anterior part of the putamen. Here we are removing the putamen. I already showed this, how these perforating arteries will perforate the lentiform nucleus. And after M2 will supply the insular cortex, M3 the operculum, and M4 the lateral aspect of the brain. Anterior cerebral artery will also arise from ICA bifurcation, but will have a medial trajectory. It will continue medially over the optic chiasm. This is one anterior view, and you can see how one ICA bifurcation on each side will originate one ACA from each side, and both ACAs will connect together through ACOM, through anterior communicating artery at midline here, just anterior to the lamina terminalis. Okay, so here's lamina terminalis, here is optic chiasm, here's ACOM. So from bifurcation to ACOM, it's A1, and A2 will be from this point on. Anterior cerebral artery will be directly over the corpus callosum. It will also be named pericallosal artery, and its main branch will be the callosal marginal artery that will get inside the cingulate sulcus and have this trajectory at the cingulate sulcus. Posterior circulation. The posterior circulation will initiate from the vertebral artery. The vertebral artery will have a preforaminal segment, then a foraminal segment inside the foramen transversum of C2 from C6. Then it will have a loop laterally and will go through the foramen transversum of C1. It's called C3, V3. And then from this loop, inside the dura mater and later on to meet the contralateral vertebral and originate the basilar artery, it will be V4. So let's focus our attention here. The cadaver, we can see here, we can see the cerebellum hemispheres, one on each side, the vermis on midline. Here is C1, and here's the vertebral artery. Okay, so the vertebral artery, it's coming here from the foramen transversum of C2 to have a lateral loop. We'll go through the foramen transversum of C1, and then we'll progress medially, and it will enter the dura mater. Usually, just after entering the dura mater, pica will arise. The posterior inferior cerebral artery will arise here. These are the rootlets of the hypoglossal nerve that will collect together and form the hypoglossal nerve that will exit the intracranial cavity through the hypoglossal canal. So this is the hypoglossal rootlets, and this is the pica. Okay, and then one vertebral artery will connect one to each other and will originate the basilar artery. And the basilar artery on its topmost will open up into the two PCAs. So we'll have the pica originate, the three main branches of this system here. We have the pica originating from the vertebral artery. We have AICA, anterior inferior cerebral artery, originating from the basilar artery, and then we have the SCA, superior cerebral artery, originating almost at the superior-most part of the basilar artery. So we can see these three origins here. Pica will supply the suboccipital surface of the cerebellum. The AICA will supply the sphenoidal part, the petrous surface of the cerebellum, and the SCA will supply the tentorial surface of the cerebellum. Okay, I already mentioned. The pica has its loops. It has one anterior medullary segment here, a lateral medullary segment here, and then it will be positioned just laterally to the vermis, and will finish itself by supplying the suboccipital surface of the cerebellum here. ACA will supply the petrous surface of the cerebellum, and SCA the tentorial surface of the cerebellum. Two arteries have an origin from the proximal part of PCA. This is the posterior choroidal arteries. We have a lateral one and a medial one. They will have this trajectory along the crural cistern and ambient cistern. The posterolateral will get inside the temporal horn, while the medial, the posteromedial will have all its trajectory along the ambient cistern and will get inside the quadrigeminal cistern, then next to the pineal gland and inside the velum interpositor. And PCA finally will finish itself inside the calcareous fissure. Now I'm going to talk just some minutes about cerebral veins. What we want to understand is the drainage will finish into sinuses, and these sinuses will join together as well and finish at the internal jugular vein. Sorry, I don't know why it's... Sorry, why it's not showing my slides here. We do have a superficial group of a superficial system and a deep system. The superficial system will drain the cortical part of the brain, and the deep system will drain the sagittal cord and the ventricles. The cortical drainage we can separate into 4 groups. We have one group dedicated to the superior sagittal sinus, another group dedicated to the inferior sagittal sinus. Let's see this here. So the superior group will drain all the cortical surface that's superior to the Sylvian fissure. It will drain into the superior sagittal sinus. We usually have a major anastomotic vein that's called the vein of Trollard. It's usually more posteriorly, but in some specimens it can also be a little bit more anteriorly. And it will open itself by bridging over the interhemispheric fissure into the superior sagittal sinus. We already showed this slide here, how these bridging veins are really bridging veins. They're just bridging over the interhemispheric fissure. Some will open like several veins, and others will open just like one big vein. Another group is the Faucine group. They will drain the medial aspect of the brain, and it will drain into the inferior sagittal sinus. And the inferior sagittal sinus will finish as the straight sinus. We'll talk about this also. Inferior to the Sylvian fissure, at the posterior, middle and posterior part of the temporal lobe, and the posterior part and the inferior part of the occipital lobes, and the inferior surface of the temporal and occipital lobes, they will all drain into the complex of Labé. And these veins, there are usually several veins, they will finish themselves at this connection, at this point, that is the transverse sinus with the superior petrosal sinus, superior petrosal sinus and transverse sinus. At this point, the veins of Labé will finish and drain all this surface here. Then the Sylvian fissure. The Sylvian fissure will have 2 main veins. The one that is superficial, the superficial Sylvian vein, it will drain into the sphenoparietal sinus. And the sphenoparietal sinus is the surgical veil. So the sphenoparietal sinus will later finish at the cavernous sinus. We already showed the sphenoparietal sinus here draining into the cavernous sinus. I already showed these slides here. The sphenoparietal sinus will join with the inferior superior orbital fissure veins are coming from the orbit through here, and then draining into the cavernous sinus, and then the cavernous sinus will open itself into the basilar sinus and the superior petrosal sinus. For the deep drainage of the brain, we'll have the one that starts with the deep sylvian vein. The deep sylvian vein will bend medially over the limb insula, will continue medially, where it joins the anterior cerebral vein to originate the basal vein of Rosenthal. So the basal vein of Rosenthal is the connection. It's originated by the deep sylvian vein and the anterior cerebral vein. And the basal vein of Rosenthal will have this circumflex trajectory, also wrapping around the crural cistern and ambient cistern, and then into the Galen, into the great vein of Galen. So here we see the basal vein of Rosenthal making this round trajectory here at the ambient cistern, and then over and merging with the anterior cerebral vein to originate the great vein of Galen. And then the great vein of Galen will open itself into the straight sinus, and the straight sinus will reach the torcula. Ventricular drainage. The ventricular drainage will have several subependymal veins. They will all collect themselves and drain into the velo-interposital cistern, where we have the internal cerebral veins, one on each side. At the internal cerebral veins, they will be located at the roof of the third ventricle, just as we mentioned already. This is the internal cerebral vein. And the internal cerebral vein will join the basilar vein. And the connection of both of them will originate the great vein of Galen that I already mentioned. This is the anatomic view of the supracerebral approach, where we can see all these vessels here. So we can see here the anterior calcarine vein, we can see the basal vein of Rosenthal, internal cerebral vein, and the superior vermial vein, how this anatomy is really complicated. And here we have the pineal here. Just the lateral approach, the pineal. And there's all these veins draining to the straight sinus and torcula here. About the inferior compartment, the inferior fossa, the tentorial surface of the cerebellum will finish into vessels that drain into the tentorial sinuses. There's, as Professor Ture said, that you don't need to coagulate them. They might have few, but they might have big and several tentorial veins draining into the tentorial sinuses. The brainstem of veins, they will collect themselves also, and a major output vein is the superior petrosal vein that is going to drain into the superior petrosal sinus. So it will drain into the superior petrosal sinus, and the superior petrosal sinus will finish at this point here, where we will originate the sigmoid sinus. So here we made the sigmoid sinus using wax. This is really at this part here, and it will finish at the jugular foramen. Okay, people, thank you. Thank you once again for the opportunity.